And I think, Kathleen, that's all I have for now. And let me introduce our partner in this project, Kathleen Stifler, with the MSU Institute for Health Policy.
Thanks, Arnold, and good morning, everyone. We're happy to bring this very often requested topic of rural health access to you today. And for those of you who in the future will be watching this as a recorded version, if you have questions, you are able to share, you can refer your questions to Arnold or to myself, and we'll be sure we can get you an answer from our presenters today. So the topic of rural health access is an incredibly important one for our state. Access to the full array of health services is important for the health and well-being of a community. That was true before the pandemic. It continues to be true today. That includes routine preventive care, episodic care, emergency care, inpatient care, substance use disorder treatment, and supports. And all parts of our state are struggling with access at different points, whether it's the workforce shortage, our pipeline issues for some of our professionals, but rural areas of our state are faced with a unique challenge. And so for those of you that might not be familiar with the rural components of our state, about 20% of Michigan is considered rural. It's about 1.8 million of our residents live in what would be considered a rural setting. About 300,000 of that 1.8 million are residents of the Upper Peninsula. So it's by far not just that most rural area of our state. So as you can see, this is an important topic. We've got the state's experts with us today to cover the important components and the important policy issues related to assuring that all residents, including the rural residents of our state, have access to care. So I'm first going to introduce John Barnas, who's the Executive Director of the Michigan Center for Rural Health. John has been the Executive Director of the nonprofit. John, remind me how long? Since February of 20, is that correct? Or 2000? I mean. Yeah, February 2000. He is responsible for coordination of all of the HRSA-funded programs and grants, policy, workforce development services, distance education, and rural primary care and value-based programs. A more complete bio of all of our presenters are available on the IPSR website, but today we'll be just doing brief introductions. So John, please get us started.
Certainly. Thanks, Kathleen. Arnold, can you flip up the presentation, please? Thanks. That was high praise. I don't know if I am an expert, everyone, but I know things and I know people. And one of the things that I do know is to hire very smart people to take care of the things that we've been tasked with by the state of Michigan and by HRSA. So I thought we'd kind of roll through this. I would give a little background on who the Center for Rural Health is, a couple of our programs, and then hand it over to Crystal, who's our Director of Programs and Services, to take a deeper dive into the issues that you want to hear about. And then Joyce will grab the baton and do the last lap and really describe what is quite an epidemic in the opioid use disorder, substance use disorder issues we have in rural Michigan, OUD, SUD, as we have the acronym. So Arnold, if you could flip to the next page, please. Thanks. So here we are. Here's who we are. So we were established by the feds in 1991. And I think what makes us unique is while every state has a state office of rural health, by its name, you would think, yes, they're inside state government. And for the most part, that's true. 37 out of the 50 are inside state government. So think like for Michigan Department of Health and Human Services or some type of Department of Public Health. There's another 13 that are actual university faculty. So my colleagues at the University of Wisconsin-Madison, Penn State University, those are all faculty at university. Then there's 3 nonprofit state offices of rural health. There's us here in Michigan, there's Colorado and South Carolina. And, if you were to talk to someone in HRSA who's overseeing the Federal Office of Rural Health Policy funding, they would say that the nonprofit status way of operating is probably the best because it gives us greater latitude to drop into programs and manage things that, typically, or maybe, someone in state government just can't get to. So I do have a board of directors. There's 3 branches of state government who are on my board: Senate, House, and the Office of the Governor. So Senator Vanderwall, Representative Aller, and then Megan Groen out of the Office of the Governor. 2 sections out of state government. I have Beth Nagel, Policy and Planning, and Emily Bergquist, who has the Bureau of Trauma and Emergency Preparedness, EMS. And then 6 trade associations. So think like the Michigan Primary Care Association, Michigan Health and Hospital Association, Michigan Association of Local Public Health, and so on. And then the dean over at the College of Osteopathic Medicine, Dean Andy. So we're located on the MSU campus, inside COM, in the 2nd floor at West Fee Hall. We share a hall with Family and Community Medicine. And we do have a second office up in Gaylord, where we run our OUD, SUD work out of there. That's where Joyce is, and we call that the Northern Michigan Opioid Response Consortium. That's now into its 4th year. So we have 3 people up in Gaylord at the United Way building, and Joyce will spend some time talking about that. So we're 11 FTEs, 2 part-time employees. Those are our administrative assistants. Those 2 are honor students. That's who we use as our administrative assistants out of MSU. Great students. We've had probably 5 out of the last 15 go to medical school. So we're kind of a small shop, 11 FTEs. 3 are located outside of the Lansing, East Lansing area. Let's go to the next slide, Arnold. Where's our revenue come from, our funding? We are highly dependent on the Health Resource Service Administration, HRSA, specifically out of the Federal Office of Rural Health Policy. We do receive an annual state appropriation of $175,000 that we use to match with our State Office of Rural Health grant. We do have some state contracts through the department to do some opioid work, some primary care quality improvement work. We're also have been subrecipients and continue to be subrecipients to other projects. Currently, we are a subrecipient to a project that is ARC funded, Agency for Healthcare Research and Quality, out of the federal government, funding to the Alterum Institute. And we're a subrecipient to that grant, working with primary care clinics in the Thumb, Cass City in particular. And then we have program fees that help balance our budget. The fees would be for like our annual conference that is at the end of this week. We run a number of emergency medical services, coding and billing workshops. So that's how we balance. That's how we fund ourselves. Depending on the year, the grants that we're receiving, our annual budget is anywhere between 8 million to 15 million. I think this year at 14 million. So that's our funding. Next slide, please. Here's just a quick list of our funded HRSA programs and non-HRSA funded programs. So as I mentioned, the state office, the Rural Hospital Flexibility Program, for those of you who've been around, that's really known as the Critical Access Program, Critical Access Hospital Program. There's a Small Hospital Improvement, SHIP COVID. So the Small Hospital Improvement, that's for a grant for hospitals that have 49 or less staffed beds to work on quality improvement. And then, excuse me, in the SHIP COVID, HRSA used the SHIP program as a mechanism for the state offices to get COVID relief money out to those 52 hospitals that have 49 staff beds or less. We have an outreach grant where Jeff Nagy in our office is working with 6 hospitals, 6 small rural hospitals, 2 tertiary hospitals to improve patient care in swing beds and also reduce the cost per day in a swing bed. Then, of course, here's Joyce's programs. Crystal has been very successful writing grants for the Center for the Rural Community Opioid Response Program. We have 3 of those currently. And then we have another RCOR grant that's psychostimulant. So we're working on 4 different grants. And then, as I mentioned earlier, the SAFER program is an academic detailing program teaching primary care providers, so think family practice doctors, PAs, nurse practitioners, on how to work with someone with OUD, SUD issues. The ETBHC is a primary care program working with Munising Memorial Hospital in the primary care setting. The Ready COVID is working with local public health to get COVID relief money out to them. Healthy Hearts for Michigan, I described earlier. And then we also received a small grant from the CDC Foundation to work with Hillsdale County and Missaukee County to increase their vaccination rates. So those are our programs. That's who we are right now. Next slide, please. Just a little in depth. So this is our core program, the foundation block of where everything else works from. So we were established in '91. The feds give all the state offices, we have to divide this up, 12.5 million. So we get about $225,000 in federal, and we match that up with our 175 state appropriation. Thank you, House and Senate members. We appreciate it. So that's our budget. Out of that, we get about 4 FTEs. And most importantly, education is the cornerstone of our program, of our state office of rural health. We provide free education to primary care providers and to specialists, think psychiatrists, social workers. So we're considered an affiliate of Michigan State University. So our education manager, Renee, is able to knock on the doors of the various colleges and departments, put together monthly and weekly grand rounds, which would be from noon to 1, brown bag. It could be on pain management, on social workers. They dial into Zoom. We'll have 120 social workers across rural Michigan get their free education. Doesn't get them the 36 hours they need over 3 years, but it helps. So they don't have to travel from like Mayo, Michigan down to Saginaw. She's also running a Project Echo, which is a very in-depth educational program on a monthly basis, working with Dr. Peter Gulick out of MSU-Com on infectious disease. We're getting about 15 physicians monthly on this. She also works on the conference with more CEUs. We have a certified rural health clinic workshops. And then our workforce manager, or who we're now calling our manager of access to care, because we're taking workforce and putting it together with telehealth and behavioral health, because those are all access to care. So our workforce manager of access to care is working to recruit and retain providers for hospitals and clinics. So she does, special things besides just going to job fairs. She's also speaking to medical students. She's taking students on road trips, having breakfast with physicians, getting juniors and seniors out of high school, rural Michigan, to the OsteoChamps program every July here on campus, and then also working to find providers to take the National Service Corps, the state loan repayment, and also works with the state on health provider shortage areas. Next slide, Arnold. Just a couple photos coming up. So here's a photo of 6 junior seniors out of high school who have already self-selected. They know they want to go into some type of medical field. That could be they want to become a physician, an RN, mortuary science, a medical assistant, but they know they've selected. And so they spend a week on campus in the dorms with faculty and students, learning more organic chemistry and those types of things. Next slide. There's a breakfast. We bring in a primary care provider. We invite any student from COM or College of Human Medicine who would like to have a couple hours just to chat and talk about how it is to practice in rural Michigan. So that's just a photo of them. I think I have one more, Arnold. Yes, we'll rent a van and we'll go to let's say, I think that's Eaton Rapids, so it's fairly close. But we typically go to Alma And the students, the medical students will tour the hospital, the primary care practice, meet with administration, walk through the downtown, get a cup of coffee at the cafe so they can see that rural life is a good life and the facilities are top notch. So that's one of the things we do to get folks thinking about practicing in rural. And I think my last slide, Arnold. Oh, a couple more. Here's our critical access hospital program. There's 37 of them in the state. Out of that program, you see that we hire 3 full-time equivalents. We have a couple quality networks, the Michigan Critical Access Hospital Quality Network, and also a certified rural health clinic quality network. And these groups meet on a quarterly basis. They're taking their data, they're benchmarking it, they're talking to each other. How do you get your quality so much higher than ours, all things being equal? So they're sharing things to improve the quality. We do the same thing with the financial officers. Jeff brings them together twice a year to benchmark and discuss things. We also do a bunch of education. You can see on the leadership academies, coding. We do monthly coffee hours with EMS workers and also rural hospital CEOs, which is kind of like safe tables. They just talk about whatever they need to talk about. Nothing's recorded, nothing is written down. It's a safe table to talk about what's going on in their life and their communities. And then some more education and service line assessments. And then the next slide, Arnold. And we do a little bit of advocacy. Last couple of years, obviously, we haven't. We typically do go to the state capitol and meet with the rural House and Senate members. And then at the National Rural Health Association, we'll go to DC and we'll advocate to fully fund the programs on the left. Those are our core programs. We want those to be fully funded to continue to work with our communities. And then as a sampling of what we might talk about for critical access hospitals, keeping their reimbursement up, and then asking them to sign on to specific legislation. In this case, it was discharge hours and transfers in less than 96 hours. So we meet with all of the rural House members and of course the 2 senators. With that, that is my last slide, and I would turn it over to Crystal.
Let's just take a second and see if we have any questions before we switch to Crystal. Do we have any questions from our participants today?
Happy to take any. There's a lot of information.
I have one for you, John, if you don't mind. The OsteoChamps program is awesome. That is really an exciting part of preparing the pipeline. But by that time in high school, are you familiar with programs anywhere in the state that are working on the STEM, encouraging STEM education prior to high school? Because by the time they get to that point, those kids it's almost too late if they haven't been exposed to that yet.
On a rural basis, no, I can't say know of any junior high type programs. That would be for my workforce manager to describe. But, I will give, some credit to her. Everyone always thinks about recruitment as always, we need more primary care providers. We need more doctors. We need more nurse practitioners. Well, when you talk to a CEO right now across rural Michigan, you'll find out that there's a vacancy rate of about 20% across all the service lines. So one of the things that we've started in Eastern UP with David John at the Sioux, or now called My Michigan Sioux Clinic, along with Michigan Works, is we've started a medical assistant pipeline program. And it's a program where people come forward and they're being trained and paid at the same time that they're learning to become a medical assistant. And then when they're finished, they have a job. They can have a job either at War Memorial, or they might go down to Karen Cheeseman's shop over at Mackinac Straits, or further west over to Helen Newberry Joy Hospital with Hunter. So we're going to start replicating that. We were talking to Jeremiah Hodshire down at Hillsdale. He would like the same thing along that Ohio-Indiana border. He's screaming for medical assistance, and we're also looking at starting it for rad techs. So kind of moved off of your direct question, Kathy, but workforce is more than just primary care providers right now.
Absolutely.
Yeah, it's across the board. It's housekeeping, it's medical assistants, it's farm techs, rad techs. We need them all. We need them now. So that's the direction we're moving in.
I don't think there's a sector that is adequately prepared to fill the need at this point. Social workers, mental health professionals, yes, it is quite a need, not just in Michigan either. So now it's not like that we're just competing within our state, we're competing across states. So thank you. Thanks, John. Any questions? I'm not seeing any hands up. Okay, well, let me go ahead and introduce Crystal then. Crystal, pardon me, Crystal Barter is the Director of Programs and Services for the Michigan Center for Rural Health, where she facilitates operational, financial, and clinical quality improvement in Michigan's critical access hospitals, rural prospective payment system hospitals, and certified rural health clinics. Ms. Barter oversees numerous state and federal-based contracts focusing on quality and performance improvement, my favorite topic. So thank you, Crystal, for joining us today.
Thank you very much. Happy to be here. So thank you for the very nice introduction. My name is Crystal Barter. I'm the Director of Programs and Services here at MCRH. Today, I am going to provide a high-level overview of the health and challenges of rural Michiganders. Rural health is obviously a large, broad, complex topic. So I hope that at the conclusion of our time together today, we meet our objectives outlined, of course, but maybe more so, I hope to continue the conversation. The Center, MCRH, and our staff are a resource, as John detailed, and we look forward to having more nuanced discussions with all of you on the health and challenges that rural Michiganders face, and then hopefully some collaboration on how we can improve Michigan's rural health. And also, it's very nice to see some familiar faces on here. So with that, I will cover these three objectives today, hoping to understand the challenges related to access to care for rural Michiganders. So we'll dive into some numbers there and some scoring criterion that we use to define access to care. Understand some health disparities and barriers that rural Michiganders face compared to their urban counterparts. We will lean heavily on a very wonderful resource that the state of Michigan, MDHHS, put together, their 2020 Michigan Primary Care Needs Assessment. So definitely making sure we're looking at that resource under that objective. And then finally, we'll conclude with understanding some challenges related to providing care. So John mentioned the rural CEO open office hours that we host on a monthly basis. That is such a wonderful insight into some of these challenges that we'll discuss today. So rural Michigan by the numbers. Kathleen set us up very nicely here around some of the population data, so I'm not going to reread that. I do want to highlight one area though. Keeping that population that we have in rural Michigan, it is a concern. I think it's a concern for Michigan as a whole, as we've seen in recent data, and rural is not excluded from that. So you can see some of the stats here. 50 of Michigan's 83 counties had population losses, including 15 out of the 16 counties in the Upper Peninsula. So the only county in the UP that did not have a loss was Houghton County. And the top 5 shrinking counties by percentage are all rural counties. So you can see them listed here. You know, I think that this is obviously a very complex issue to understand. Are people leaving for economic prospects, the younger population leaving to go to school and maybe not returning? But I do really think it's important to note, as it does impact some of the issues that we'll be discussing today. Our healthcare system is built on a system that rewards for volume. We're moving to value, which is great, but we're still primarily volume. So as our rural communities lose population, this is definitely an issue. In addition, the economic challenges that population loss creates does have a major impact on the ability to recruit and retain those providers that we'll be discussing today. And in addition, it has an impact on bringing additional healthcare services to the community. One thing you'll know in this map on your left here is that while we'll be discussing, you know, rural as a whole and how it's adversely impacted on some of these topics today, You will see consistent pockets of red. So rural areas that unfortunately, you know, are performing poorer, have more opportunities than some of their other rural counterparts. And you'll also see rural areas that, you know, are consistently performing fairly well. I think we can all kind of name those. It's the, you know, the Grand Traverse, the Leelanaws, the Petoskey's of rural Michigan. But I think that's one thing to note as we're looking through some of these maps today. So rural Michigan by the numbers, providers. Rural Michigan needs more providers. I don't think anyone on this call finds that shocking, but we will dive into these numbers in a bit. But frankly speaking, rural Michigan does need more providers. Around 3 million residents are underserved in primary care, about 1.5 in dental, and a staggering 4.2 million do not have access to adequate mental health services. And this is just something that, you know, our office is working with a variety of partners to try to remedy, but it is a very complex problem that needs a holistic answer. So looking into, you know, how we define access and some of these shortage designations. These slides are primarily resources, I'll say. I'm not going to read them word for word, but I do think it's important for us to kind of set the stage on what the structure is that the federal and state government use to identify and measure shortage areas. These designations do allow for very specific resources to be provided to certain geographic areas, facilities, or populations. So health professional shortage area, excuse me, HPSAs, we will be discussing them quite a bit in this presentation, and then MUAs or MEPs, and you can see the various definitions right here. Again, not going into great detail here, but did want to provide you guys some context on how the HPSA scoring calculations are calculated for the 3 different HPSAs: primary care, dental health, and mental health. You can see the examples on your left of the measures that are part of that scoring criterion. Travel distance, obviously, that's something that rural populations deal with. Transportation is always something that our rural CEOs, rural practice managers, local public health, community mental health are trying to fix. It's a barrier to care that we have not solved yet. And that's something that this methodology definitely takes into consideration. I'm not going to go into great detail here, but did want to obviously give you the scoring criterion for the MUAs as well. So this scale is from 0 to 100, with 0 corresponding to absolute complete underservice and 100 corresponding to the highest level of service, with scores on the scale determined by adding the weighted values for these 4 variables that you see on the bottom of your screen right there. So getting into some maps, the higher the HPSA score, the greater the need. Once designated, HRSA does score the HPSAs on a scale of 0 to 25 for primary medical care and mental health, and 0 to 26 for dental health, with, again, the higher scores indicating the greater need. So this is our primary care in 2021. You can see some pockets of rural and urban that are definitely underserved within needing primary care medical care. Upper Peninsula, this northeast section of rural Michigan, we tend to see kind of light up a lot on these maps. And then you can see along the lakeshore as well. Dental health, here's the map around the HPSAs related to dental health care. Again, that darker purple, mid-Michigan, northeast Michigan, lack of dental health care providers. Mental health, this is where you'll see that bright blue, a dark blue, significantly showing the need for mental health professionals in rural areas. Joyce is going to be talking about the work that we're doing in northern Michigan around substance use disorder and how that's evolving into mental health care. But you can kind of see on this map just the dire need for mental health care professionals in that region. And that's something, you know, our office is trying to work through with the Munson healthcare system and the My Michigan healthcare system in a recent grant application. So more to come on that. So the HPSAs are one way, and then another resource I think that's pretty important to show is just the sheer numbers when it comes to provider availability. So if you look at this map, it is pretty shocking to really think that almost 30% of our counties in Michigan have absolutely no psychiatry care, no psychiatrists available. When you think about the patient populations in these communities and how that must impact their access to care, it is quite staggering. We are seeing advances, as everyone is. With COVID, we did see quite a staggering amount of our healthcare providers ramp up their telehealth services, especially related to mental health, so in behavioral health. So it was something that we're kind of considering a silver lining out of COVID, but we still do not have access to physical providers in almost 30% of our rural counties. All right, shortage designations, kind of going back really quick. I did mention that there's specific designated resources based upon the HPSA or MUA, MUP. So this is just a nice kind of visual for folks to have that aligns the various resources from states and federal government related to the different geographic primary care and population HPSAs, MUAs, and MUPs. Our office works really closely with the state of Michigan on the Michigan State Loan Repayment Program. Our office works very closely with HRSA and the Federal Office of Rural Health Policy around the National Health Service Corps, and the CMS Rural Health Clinic Program, as well as the J-1 visa program. So, as you're working with your different populations, if you do have any questions around how these programs might be advantageous to your providers, please feel free to reach out. All right, so now that we have kind of like a baseline for an understanding of access to care issues by the numbers, really focusing on the infrastructure for assessing need, HPSAs primarily, and really showcasing the dire need for healthcare providers in rural Michigan, let's move on to what types of providers are in rural Michigan. Our office works very closely with all the provider types in rural Michigan. John mentioned that before and kind of outlined that for you guys with the various grant programs and subcontracts that we have. But I would like to dive into two specifically today: the critical access hospitals and the certified rural health clinics. These are two provider types which are designated based upon their geography, which is rural. And you can see kind of a map right here around where the rural providers are in Michigan. That does include very important safety net providers. The federally qualified health centers do incredible work in rural Michigan, and the PPS hospitals, which John mentioned around the SHIP program. We will focus on the critical access hospitals and rural health clinics today. So critical access hospitals. There are 37 in the state of Michigan, 11 in the UP, and they range all across the span of Michigan. So all the way from the Western UP, we have the Aspirus system with 4 critical access hospitals in the state, all the way to the southern border, Ascensus, Gorgeous Lee's down there, and then everything in between. So the thumb of Michigan, the Lake Shore, there's critical access hospitals across the entire state. I'm not going to read this word for word by any means. I'm sure most of you probably have reading regulation as part of your day job, so I will let you do this. But the program was established really in response to something that we're seeing again today, and that's rural hospital closures. So the program was established to combat the smattering of rural hospital closures we saw across the nation. The designation is a federal designation, and it is designed to reduce the financial vulnerability of rural hospitals and improve access to healthcare by keeping those services available in the rural communities. So once the designation is received by a particular hospital and they meet the requirements, they do receive something called cost-based reimbursement, which I'll touch on that in just a minute. Hospitals must meet the following conditions to obtain critical access hospital designation. So 25 or fewer acute care inpatient beds, Location requirements, so 35 miles from another hospital. Maintain an average length of stay of 96 hours or less for acute care patients, and then provide 24/7 emergency care services. The last two conversions for the critical access hospitals in the state of Michigan were Spectrum Pinnock and McLaren Thumb in Bad Axe, Michigan. So our office, as part of the Medicare Rural Hospital Flexibility Grant Program, we work very closely with the state of Michigan, licensing and regulatory affairs, to assist those hospitals in that conversion application. So I mentioned the benefits, and kind of the intent of the program is to ensure that there's access to care in rural communities through keeping a provider type in that rural community and not allowing the doors to close, essentially. So part of that benefit is what's called cost-based reimbursement. So critical access hospitals are eligible for this cost-based reimbursement, which takes allowable costs. There's criterion around what's allowable, plus a 1% uptick in reimbursement, which sounds great, right? It sounds great. But as of 2013, with sequestration, they're now subject to that 2% reduction, which we're seeing among other provider types as well. So really, critical access hospitals as a whole are losing money on services provided to the Medicare population. That is something that, our office consistently tries to work with our national associations to bring to light with our federal and state policymakers, but it is something that's definitely a barrier to care at this point in time. Certified rural health clinics. There are over 200 in the state of Michigan. And I like to highlight this provider type because I do think that they don't get as much recognition as they should. So our office tends to be rural health clinic cheerleaders, which is great. So another designation by the federal government, location requirements, as you can see listed here, and then some staffing requirements. So the team-based approach to providing healthcare to a rural community is really at the core of this program, of the Certified Rural Health Clinic program. So they must employ a EPP, so an NP or a PA, at least 50% of the time during operational hours. And again, really the intent of that is to ensure that there is that team-based approach to care. With the certified rural health clinics, I think, we have two slides here on kind of the nuts and bolts of what they are and what their requirements are. So that's for your reference. But I think the take-home message I would really like to happen today is that they are safety net sites. They provide a majority of care to Medicare and Medicaid populations, similar to their counterparts, the federally qualified health centers. But the difference is they do that with no, HRSA funding for operations, infrastructure, or innovation. So 200 of them in the state of Michigan, and truly are safety net sites providing care to the most vulnerable of rural Michigan residents. So we will move into some high-level disparities. The image you see on the right hopefully is not new. Looking by the attendee list, it's not, I would assume, for all of you, as it has become widely accepted in our industry as a basis for understanding how environment impacts our health. So we'll kind of talk about some of these factors today. But rural Michigan, due to things like higher income inequality, higher poverty rates, smoking, and less resources, such as the provider resources we just discussed, and things like broadband, are adversely affected when we look at healthcare outcomes and social determinants of health. So one I mentioned earlier, a key resource I hope that everyone takes home and is familiar with is the primary care needs assessment data that the state did in 2020. It's a really great report. And more importantly, if you're working in specific counties or specific regions, they do have one-page state profiles that kind of break down all of your chronic disease data, your social determinant of health data by county. So that's really valuable for analyzing, comparing county to counties, and then assisting in providing resources to specific counties through things like grant funding. So I wanted to call that out for everyone. So as part of that report, they analyze health outcomes and social determinants of health. You can look at some of the measures right here, and I'll highlight a few of them. And we'll find out that, rural Michigan is adversely impacted when it comes to social determinants of health rankings, and there's a great need there. Demographics on the left-hand corner, you can see those right there, pretty straightforward. Poverty level, population, high school diploma, that's something rural Michigan is adversely impacted by, and food insecurity rate. This is something I think that rural Michigan tends to have a narrative around it that maybe isn't true in some circles. So when folks, tend to think about rural Michigan, tend to think about agriculture, which is wonderful and very true. But a lot of our rural Michigan residents suffer from food insecurity. Just because the food is grown in their community, grown down the road, does not mean they have access to fresh fruits and vegetables. So I think that is a narrative that, our office can continue to dispel and also provide resources around. Health risk factors, that middle column right there, physical inactivity, that's an issue in rural Michigan. A lot of communities don't have access to things like, sidewalks and safe places to walk. Unfortunately, maternal tobacco use is something, especially in that northern lower part of rural Michigan, is something that is just through the roof when we look at the rates compared to urban counterparts. We actually had some Michigan State University College of Human Medicine medical students do a poster presentation at our last annual Rural Health Conference on this issue. It was just shocking data. And then some healthcare access and preventative service data. You can see there, we discussed the population ratios to providers and then some hospitalization rates as well. So when you wrap all that data up, you get obviously rankings. So you can see right here, the higher scores are primarily rural. We do have some rural areas in that lower ranking, like Leelanau, like I mentioned above, or mentioned before. They also correlate with, higher educational attainment, higher income. There is a lot of income inequality in Leelanau County, but for the most part, you can see that there are rural is adversely impacted when it comes to the need around social determinants of health. Another finding from that report that I just want to call out very briefly is around morbidity and mortality. If you guys are not familiar, this is a great resource around morbidity and mortality, but the CDC is also doing the weekly morbidity and mortality reports, and they do have some really excellent rural urban data from a national scale. So I would encourage folks to look at that if that's something that they're interested in as well. You can see these maps, again, the swath of rural areas that are in that darker green around diabetes and cancer incidents. We're seeing that northern lower Michigan pockets, obviously some of the Upper Peninsula as well. Same findings around mortality. One area that our rural CEOs discuss a lot when they're talking about providing access to care is really providing adequate care to moms and babies. And that's something that the state primary care needs assessment report found as well. So in Michigan, 57 rural counties, only 29 hospitals provide maternity care. There's a variety of reasons for that. Reimbursement is one. 50% of rural births are Medicaid in Michigan, and unfortunately, that payment does not cover the care that's needed. And then staffing. So you cannot just have one provider working in your labor and delivery unit, and recruitment and retention of those providers is very, very hard. We do have a success story in rural Michigan. I would like to highlight that. I didn't put them on the slide, but My Michigan West Branch recently reopened their maternity service line and labor and delivery service line. And we had raced over, present at our annual Rural Health Conference last year on it. And just the community impact and how the community has embraced that service line thus far has been really, I think, motivating for other rural hospital CEOs to really assess what bringing this back to their community might look like. So continue to watch My Michigan West Branch. We're really looking at them like a success story of bringing the service back to rural Michigan. And one other additional area here, it's an area of opportunity, I think, is we have a lot of work to do when it comes to infant mortality rates in rural Michigan. You can see that here. But there's also a lot of work to do around infant mortality rates on racial and ethnic data. So we do know that Black mothers are at 3 times the risk of infant death than white mothers. Unfortunately, we do have a data gap on this, on how that plays out in rural Michigan. We are working with the state MDHHS on bringing in a rural epidemiologist, so an epi that can really look at health disparities from that rural lens and dive into some of this very, very important data. We do know that that's a data gap that we look forward to exploring more on how that very important disparity element does impact rural Michigan. Here's a map around the population to FTE ratio again. Just showing the lack of OB care combined with the lack of maternity service lines in some of our rural counties. These are the maps combined. So quickly, I will conclude with our last objective, which is around challenges to providing care. So we touched on a few. Broadband has been brought up by our rural CEOs. I know that the state of Michigan and other collaborators are working very hard to bridge that gap. But we do know that rural Michigan is adversely affected when it comes to broadband access, and that not only has impacts on the healthcare industry, has impacts on education, economic, etc. So we touched on that. We did touch on OB services and maternity care. That is something that we hear quite a bit from our rural hospital CEOs. We also hear about EMS. In today's day and age, it would be a miss if we did not bring up the impact that rural emergency medical services has on providing high quality care to our rural communities. So we are seeing a lot of opportunity for rural EMS services. They are at a time where we definitely need to expend resources to support this vital safety net service to rural communities. Staffing is problematic. Rural definitely has a higher percentage of volunteer staffing for our EMS agencies, and that number gets higher as you go north. Upper Peninsula, Northern Lower Michigan, very high percentage of agencies that are staffed by volunteers. And there tends to be lower wages as well for the agencies that are able to have paid full-time on staff. The payment model, reimbursement is for transport only. We did see some innovative models come out from CMS, specifically around, COVID, and hope that those continue. But for the most part, reimbursement is for transport only, not allowing for coverage of those readiness costs that we need covered. So that overhead costs, providers, equipment, etc. This is, rural agencies are impacted by this at, I think, at a greater scale, just due to their lower volume of where they're located. And then finally, we are hearing a lot from our rural CEOs about the lack of staff and the lack of infrastructure within our EMS industry is impacting not only the quality of care for the patients, but it's also impacting the ability for our rural hospitals to get those patients to a higher standard of care. So if the EMS agency does not have the ability to provide those long transfer services for whatever reason, then that does lead to increased length of stay for our rural patients. The last thing I'll close with is our population health manager recently conducted an analysis of all the rural Michigan hospital community health needs assessments. So this is a resource that I included in the slide deck and is on our website. And I think, as everyone's aware, all nonprofit hospitals have to conduct what's called a community health needs assessment every 3 years. So that includes, analyzing their service lines, connecting with their community on what their priorities are, data analysis, and looking at health disparity data. So those are all publicly available on hospital websites. They should be easy to find. And Sarah in our office went through and analyzed them with a rural lens. And two priorities that I'll kind of touch on. And the last one is a nice segue into our third presentation today that Joyce will give. First, access. We touched on that. 61% of hospitals identified this as a top priority. We discussed that, but access to care, really making sure that folks are aware of what hospitals provide. I think independence and system-based facilities, there's always room to show your community, you know, what care you can provide in that is local to your community. So room for enhancement there. And then just as we noted before, just increasing the number and specialty services available for folks. 74% of hospitals in rural communities identified mental, behavioral health, substance use disorder as a top priority. Our office, as John alluded to, has been fairly successful in working with rural Michigan communities, specifically in that northern Michigan region on substance use disorder, which you'll learn about from Joyce. But I think one thing that we've been, proud of rural Michigan communities over the last 5 to 10 years is how they've tried to step up to address this issue in their communities. We're seeing a lot more emergency departments start to employ professionals like peer recovery coaches, which you'll learn about. We're seeing a lot more emergency departments implementing that or MOUD in their emergency department setting. And our office has been proud to kind of play a role in that in rural Michigan. So resources and additional information, I will build that out, but here are two that I mentioned earlier. And with that, I am available to take questions.
Thank you, Crystal. Wow, that was a ton of excellent information to better understand the status of the rural communities that are served by our health system. We have one question that's in the chat, and I'll just read it out for you and for all. I'm pretty sure everybody can see it, but I'm going to read it out. On the maternal infant health slide, you mentioned the reimbursement rate in Medicaid as being one of many challenges that exist for rural care. Are there any suggestions on ways to better quantify this reimbursement gap? How far away from covering the actual cost of care in a rural setting, for example? Medicaid fee schedule uplifts, those suggestions. Are there solutions you've identified?
So what I would suggest, and John, feel free to step in here, but Dominic, I would love to bring together the My Michigan West Branch team and then some rural hospitals that we know are looking at potentially bringing the service back to their community and doing a kind of a think tank brainstorming session with that group. I think that would probably be the most efficient and applicable.
And I agree, Crystal. I think if you brought together My Michigan and a few other rural hospital CEOs that one time had OB services to chat with Dominic and with MSA and any other House or Senate members that'd be interested, that's the first step. And I think it's always important to remember that no hospital CEO ever wanted or wants to close OB. That's like the happy service line, right? Babies are born. Is there anything more thrilling and exciting in a hospital than when a baby is born? Usually there's music played over the speaker when the delivery has occurred. But you need a minimum of 2 and sometimes 3 OBs because you have to have one working, one on call, and then someone's going to go on vacation. So you need that third one. So it's costly, OBs are costly and so is the insurance, and you need a number of deliveries to keep everyone's skill level up. So as you know, Dominic and everyone else on the line, it's complicated, it's expensive. No one wants to close OB, but I mean, that just, it happens because you have to keep your hospital open too. But I'd love to get My Michigan, to get Ray Stover, get Peter Marinoff, get some of those folks together and just talk, just chat about this and see if there isn't a way to have this happen again.
Any other questions for Crystal? I have one if I don't see any others. Okay. Crystal, you mentioned telehealth as one of the sort of the silver linings of the pandemic, and I couldn't agree with you more. The growth of telehealth. Do you see, and especially around mental health services, it was really pretty robust around mental health services pre-pandemic, and as you know, even grew more during the pandemic. The UP, I think we all have known they've had an excellent telehealth, telemedicine system within the UP for a very long, very long time, you know, sort of self-preservation given the distances between communities in that very rural, but, you know, large geographic area. Do you think that all of the gains that happened during the pandemic will be sustained now and into the future?
Yeah, that's a good question. So we are getting inclination that the waivers that have been extended through the public health emergency will continue, that have benefited rural communities around telehealth. So hopefully that is truly the case, and that does continue. And then our rural providers, I could not agree more. I think they really stepped up. They're seeing the benefits of providing telehealth to their communities. And there's been this this conversation around, you know, do rural, maybe a little bit older population, will they adopt telehealth technology? I think we've been surprised and pleasantly surprised. I think that there's always going to be pockets of folks, but for the most part, folks are adapting to our telehealth advances, and I think that will continue.
Well, that's some good news. Thank you. Okay, so let's move on to our last presenter for this session, to Joyce Fetro. She is a project director with the Michigan Center for Rural Health, Northern Michigan Opioid Response Consortium. Ms. Fetro is a person in recovery, a certified peer recovery mentor, and a certified community health worker. Ms. Fetro is vital in moving the recovery-focused activities forward, including providing education to the Northern Michigan Opioid Response Consortium members and their associated clinicians on multiple pathways to recovery and facilitating the peer recovery coach trainings. So thank you, Joyce, and it's all yours now.
Well, thank you. And again, we appreciate this opportunity to be able to deliver this information, and I'm happy to be able to share it with you as well. So again, my name is Joyce Fetro. I'm the project director for NWORK, is what we normally go by, but that stands for the Northern Michigan Opiate Response Consortium. And let's go here to my next slide. There we go. As John alluded to earlier, we have 3 grants that focus on the opiate use and substance use disorder. The counties that are highlighted there kind of outline those. And then additionally, we have 9 counties that we focus on psychostimulants. So in 2018, when we first started the RCORP planning for these grant opportunities, we did so with opiate use in mind. And through that process, we learned that when we put a focus on one substance or one weed, as I call them, other weeds tend to pop up. And that's what we've seen with methamphetamines, amphetamines, and psychostimulants. But all the while, alcohol has always been the #1 killer. Opiate use, to date, over 191 people die in the US from opiate use disorder. And that's over 300 people combined from all substances. So over 300 people die every single day from substance use. That would be like a major airline plane crashing every single day. And if that was to happen, we'd all be doing something about it. But it's so sporadic and spread out that sometimes we don't really recognize this impact that it has had. But in areas in our state and rural areas, we have, of course, I'm sure many of you are aware that we've got grandparents raising children, and that we have children that are, fallen into the system due to their parents, deceasing from substance use. The NWORK is a 49-member consortium. We're spread across the 21 counties, as you see highlighted here. Our members range from federally qualified health centers, rural health centers, treatment centers, detox centers, law enforcement, the judicial systems, local public health, schools, and just to name a few. But we really look at the main function of what MWork is collaboration. And we work with all of our project partners to make sure that there's no duplication of efforts and that we're using the funding and their funding that is being used wisely is to avoid that duplication, but also to be very impactful and make sure that we're providing the services to these rural areas. I will also point out that substance use is not restricted to just rural areas. What makes the substance use in some of these areas very difficult to manage is the access to care and resources available for those who suffer. And as I stated, we originally stated with a, went with these grant opportunities with a huge focus on opiate use disorder. And we tailored our mission to make it more all-inclusive in that we're focused on all substances combined. Why were these 21 counties selected and how? We went by some CDC guidelines. One of those would be the high rates of communicable diseases such as HIV, Hep C, and other things that can come from substance use, but also looking at poor economic factors, poor health conditions, social and behavioral barriers, prescribing patterns that would be with our physicians or providers. What we know today is that 4 out of 5 individuals who use heroin started with a prescription that was prescribed by their doctor. And often they build up a tolerance. They, would then, Dr. Hop or Dr. Shop. And then we implemented such programs as the Michigan Automated Prescription System, which allows providers to look at if someone is using another doctor to get those prescriptions. So we have that high-level overview on that stuff. But another reason for these counties being selected is because of high overdose occurrences and overdose deaths from substances as well. Our work with MWork focuses across 4 buckets: prevention, treatment, recovery, and workforce. And I'll dial into each one of these specifically in a little bit. But I also want to highlight a couple of programs that we've implemented. We do look at Narcan distribution. We are nowhere near the saturation level that we need to be with Narcan. We are not the only provider of Narcan through distribution at community events. A lot of our other project partners do this as well. But we also partner with EMS, and they've implemented a naloxone leave behind program. So whenever there is an occurrence of someone who has overdosed, EMS responds the next within 24 hours to go to that home, offer Narcan, offer resources, and provide that education. They go into the homes with often a medical professional, an EMS person, sometimes a law enforcement person if needed, and then a peer recovery coach in some areas that can work with that individual who may be overdosed and help support them in either getting access to care or counseling services or whatever it might be. We also provide Narcan and naloxone upon release from many of our jails, and provide the resources for individuals to access MAT, which is medication assisted treatment, also known as medications for opiate use disorder. We also partner with other partners and looking at our harm reduction sites, local public health, and then promote opportunities through Next Distro, which can provide Narcan through direct mail programs, our local pharmacies. And right now we're partnering with the Michigan Library Association, where we've implemented naloxone safety kits in our libraries in many of those counties that you saw highlighted in the 21 counties. Casinos, schools, community centers, recovery homes, anywhere that we can get this awareness. And the naloxone safety kit, I'll show in a minute here, is typically mounted next to an AED And I'll share that with you. And then of course, the last note there, naloxone vending machines, I'll also show you what that looks like. We developed a naloxone resource card that we promote at community events and distribute to our almost 50 member organizations for to provide that awareness. We know that naloxone prevents deaths, and anytime that we can prevent a death is another opportunity to provide recovery options for somebody. Here is a opioid overdose safety kit or naloxone safety kit. Inside that red box, there is a set of gloves, a rebreather mask in case CPR needs to be administered and protecting that individual giving it. It has a instruction or tearaway manual in there, and then 2 doses of the naloxone for someone needing to administer it. So we have this in many of our libraries, community centers, and recovery homes currently. And we recently had outreach from one of the casinos in Emmett County who is wishing to implement these as well within the casinos. Here's a list of all of the places that we have those naloxone safety kits, and we're continuing to work this list and gain more traction with it, of course. And this is the naloxone vending machine. So we have one of these in Baldwin in our harm reduction site. We've seen them implemented in the lobbies of certain jails. So individuals can walk up to the vending machine and get free naloxone. Also having them installed in college campuses and local community colleges as well. Looking at those 4 components that I spoke of earlier, prevention, what that looks like is offering the mental health first aid training to community members, law enforcement, our jails, our judicial systems, and many of our hospital systems often don't know the full awareness of what substance use is or how to offer someone help and resources. So the mental health first aid training provides a lot of information on that. Individuals are equipped at the end of that 8-hour training with resources specific to their area where they can help refer someone, but it also helps recognize the signs and symptoms of substance use disorder. There are certain behaviors that individuals can present as, and sometimes we often think that those are substance use related, where in fact it could be something else that's related to their health, such as an insulin shock or a diabetic shock, or even a panic attack. And there's a process for providing support to those individuals that are needing care and services. Really, one of the main components of mental health first aid is that just showing some compassion and care and supporting an individual who's really going through a difficult time. Local FAN chapters, FAN stands for Families Against Narcotics. So this was a program that was started with a former circuit court judge who shares her own story and experiences with her daughter's substance use. And when she was going through it, high prominent person in her community, she found that she did not get any help or services and often was met with stigma and unsupportive people at all levels. So she's like, I need to make a change. And now we have Families Against Narcotics chapters. We have 3 of these in that 21 county area. They do hybrid meetings to the community, so you can either attend in person or by virtual. We even have people that are continuing to join these meetings on a monthly basis, and some of them have been as far from Canada or other states due to that stigma and not wanting to be recognized as this being an issue within their family. So people will often outsource things beyond their community because of the fear of stigma and that reputation that they have to hold. Promoting harm reduction services. So our local public health can provide lots of different services, but also Harm Reduction Michigan, where we're providing naloxone, syringe service programs, services for safer sex, which reduce communicable diseases, but also through those services provided, there's usually a peer recovery coach that's integrated into that staffing model that can help give that support and encouragement, utilizing skills such as motivational interviewing, and get that person towards a level of recovery and out of substance use, and looking at how they can manage their substance use and find a level of wellness and recovery. When we look at treatment, we want to increase the expansion for medication for opiate use disorder. Medications, these would be things such as Subutex, Sublocade, Suboxone, or methadone to treat opiate use, and increasing those clinics. But we've also looked at some of our providers that can become waivered to provide this as well. We have a few clinics that offer this, and it's just not enough. People often have to travel long distances, sometimes up to 45 to 50 miles in order to go to a clinic that provides such services. And we already know that transportation is a barrier. So when one of those things break down, that person is usually left without services and unable to, find that level of wellness. We want to increase behavioral health access. We have identified many of those professional gaps, as Crystal stated earlier in her presentation, such as psychiatry, social workers, and sometimes even peer recovery coaches. We have gaps in service areas and coverages. We also want to increase the utilization and promote programs such as the Michigan State Police Angel Program and Hope Not Handcuffs. Both of these programs, while they look a little bit different, the Michigan State Police Program, someone can walk into any Michigan State Police post, surrender themselves, and get access and treatment that very same day for their substance use. It is basically a no questions asked. Through the Michigan State Police, if the person does have an open warrant or they're currently on probation, there are restrictions to that. They do want those things resolved ahead of time, but they still offer the encouragement for individuals to keep seeking that treatment. But additionally, we have another complementary component, and that's Hope Not Handcuffs. Someone can call into the Hope Not Handcuffs program and receive access to care, again, that same day, and then receive ongoing supportive services throughout. Our workforce component would be promoting programs such as Michigan Works. So Michigan Works has a couple of different things like Fidelity Bonding Program, which supports individuals that maybe have blemish backgrounds or criminal backgrounds that find it difficult to find meaningful employment. They've also implemented in our counties the Northern Michigan Opiate Workforce Alliance, where not just the individual who struggles with substances, but their family members can also take advantage of the services offered to find meaningful employment. They can help with clothing needs for, if there's a dress code or work boots. Michigan Works helps support with that. Some often transportation, but also resume writing, cover letter writing, and then even some practice with some interviewing skills. We additionally promote programs such as Future for Frontliners or Michigan Reconnect, where individuals can return and get either their GED or start those college courses to better themselves and for longer sustainability and employment. Promoting programs such as Michigan Clean Slate Program and the automatic expungement, but also we've hosted a couple of expungement clinics throughout the region and continue to do so, so that people, again, can find meaningful employment, get some of those things expunged, and be integrated back into their communities and be productive citizens. And then also looking at recovery supportive workplaces. So we know that often individuals need to balance out their stress. They need to be able to attend their counseling meetings. They need to connect with their recovery supportive meetings, and finding those employers that are willing to employ those individuals, but also make sure that they have time to engage in such activities that are important for their recovery is huge. And we've got quite a few organizations that do this already. We promote a program called Recovery is Good Business, and this was developed out of Dawn Farms in the Ann Arbor area, where they can receive guidance and how to even support an individual who is in recovery and what that individual needs versus someone else. In our recovery component, we know that not everyone recovers the same way. I'm sure if I was to rattle off a couple of support group meetings, many of you would only probably recognize the 12-step as an avenue for people to find a level of recovery. That would be our AA and NA, but we have things that are way beyond that. In one of them, looking at faith, how someone recovers sometimes depends on the faith or religion or background that they had. So we have even expanded into, there's AA for the agnostic, AA for the pagan, just to give you an example. But then there's people that, faith is really much a very big, huge part of their life. And there's pathways such as Celebrate Recovery, where it clearly defines that higher power, or the person that can help them through that crisis as Jesus Christ. So you can see that while AA and NA were started back in 1938, and that's the one that's mostly known, we've certainly branched out, and we've found that there are pathways for everybody. And some of them don't include any religion or faith attached to them. In the MWORK region, we want to continue to support recovery community organizations. These are organizations that are comprised of individuals with lived experience. They have a board, they have a governing board, and then they usually have a mission and vision. And each one of them can look very different. Some of them could be focused on community navigation and how to access services, while others are looking at fair treatment for those who are incarcerated that suffer from substance use or mental health disorders. Recovery housing is a huge component that we're focused on. We know that people won't be able to access services unless there's things in that community that will help them. One of them being recovery housing. Two would be transportation, and then often childcare. So looking at all those components in that community and how to best support somebody. But one of the barriers that we find with recovery housing is that at the local level, we're often met with, they don't want those people living in their community. However, those people already live in that community. We're just failing to recognize it. And what they need is supportive housing in order to be safe and continue on with their treatment and their recovery. As I stated, looking at individuals with lived experience engaged back into their communities. And I shared with you that I am a person in recovery. I will tell you that, I never used to volunteer in my community. And I will say now that if I was to get paid for all the volunteer efforts that I do, I might just be a millionaire. I try and do as much as I can to give back and to help others who are struggling. And I know I'm not the norm. There are many of us that do the same thing, and we often do as much as we can to support others that are struggling. And then, as Crystal had mentioned, peer recovery coaches. Currently, we have peer recovery coaches who are working in our emergency departments to help support the hospitals with individuals who present sometimes at the emergency rooms for the common cold. But one of those things that need to be fixed in that process is that they don't have a primary care physician. So a peer recovery coach can often identify someone who does present at the emergency department for a multitude of services, from something that is very critical to even something that is a lot less common, like a sore throat or a urinary tract infection. Pairing them and getting them connected with a primary care physician will greatly reduce that when they can start to build that relationship. But additionally, we have peer recovery coaches who are working in many of our recovery housing complexes, veterans housing complexes, local public health clinics, detox centers, treatment centers often integrate peer recovery coaches into their organizations to help support those individuals. And then with today's presentation, we also shared the economic benefits of long-term recovery. So there's a return on investment for highlighting those people with lived experience and making sure that they have those things that are going to support them in their overall wellness towards recovery. And I'll share that little flyer if you didn't get a chance to see it. But these are the economic benefits of someone in long-term recovery and why we need to highlight those. But individuals in recovery often pay their bills on time and they reduce their debt and often look to have a good credit standing. They start their own businesses at 2 times more likely the rate of someone who is not in recovery. They pay their taxes and they vote. They often go on to own their own home or property, and they volunteer within their community or organization of interest. So again, lots of benefits for championing those people or highlighting those individuals with lived experience. And then I shared a lot with you about what NWORK does. I host a monthly call where we collaborate with other rural community opiate response grantees. And there's a map that kind of highlights all the other grantees that we partner with. We use this monthly call as a way to network, share successes and challenges, and often discuss barriers. And there's often someone that has already found a workaround to those barriers that we often find. And lots of great sharing and networking that goes on those calls. And we learn from each other. We learn about new programmings and new resources. And so it's a very effective call just to kind of bring that wellness to the overall state and create some synergy around that. On the NWORK team, there's myself and a medical director. We also partner with a medical director on our psychostimulant grant, and I should have included that in here, and that's Dr. Rob McMorrow. But we also have 2 project associates that support these efforts, as well as a substance use disorder coordinator. And of course, we have a NWORK website, and then you can find us on Facebook, Twitter, and LinkedIn. And that is the end of the presentation. Does anyone have any questions or comments for myself?
Thank you, Joyce. Again, tremendous information. We really appreciate everything you all have put together today for the group and for those that'll watch the recording. We do have a question that's come in for you. Excuse me. Do you have any data on how many of the opioid overdose kits have been used so far? You are using many innovative sites to make those available.
So the number of kits used, we did reach out. There's a couple of things. We don't know how many kits have been used, but I will tell you since last fall, we have distributed over 500 within that NWORK region. And again, that's not even getting near a saturation level. That's not even enough. We did reach out to Next Distro, who does provide the mail-based services to kind of get where those are being mailed out to, so that we would know by zip code, maybe something else that needs to be looked at and how we can, maybe complement that with maybe some other Narcan giveaway events. But as far as how many have been used, we don't have that number. What we have found though, is that sometimes with the use of the Narcan, that 1 or 2 of those is not enough. And there's generally 2 per box. One of the things we didn't discuss is that some of the substances that are out there are often laced with other things such as carfentanil and fentanyl, and more than 2 doses have to be utilized. We recently did also partner with a vendor to get some more insight on a higher milligram dose that's being developed to combat those carfentanil and fentanyl laced products. But surprisingly, we're also finding that when individuals either seek treatment services, there's often drug testing that's provided to see what is in their systems so that they know how to treat that individual effectively. And even the individual is often surprised as what is maybe in their system. So they may be getting that from a source and unknown to them, it has been laced with something else. making it more powerful, stronger, and harder to combat that dependence. But we can certainly look at maybe getting some data for that and providing that at a later date, but I don't have those numbers specifically for you today.
Thanks again to all of our presenters. We're actually right at time now. I'm going to turn it back to Arnold for closing comments, but we really, this was excellent information today. I hope many more people will view the recording. Thanks again.
Yeah, I certainly agree, Kathy. Fantastic information. Greatly appreciate you three for sharing the work that you do and your experiences and perspectives. We'll certainly be posting your PowerPoints, and as I noted, we are recording this session, so we'll also make it available to the entire group. And I would say be on standby, because the issues that you all are working with are ones that are not just one time only, but are continuing. And I'm sure we'll be making use of your experiences and expertise, perspectives in the future as we move forward. Thank you again, Kathy, for another excellent session. And again, to the Michigan Health Endowment Fund for their continued support. And we look forward to seeing you again. Thank you all.